Today's topic of discussion is active management of labor, particularly active management of third stage of labor. What is labor? Actually, we use both the terms labor and delivery interchangeably, but this is not true. Labor actually means, labor or childbirth or parturition means series of events that occur inside the genital organs in an attempt to expel the viable products of conception through vagina to the outer world. This is called labor. And labor may be, if it is completed, so to define labor, the pregnancy must reach beyond the age of viability. But if the baby is delivered before 37, after the age of viability, but before 37 completed weeks, it is called premature labor. And if it is delivered within 38 to 41 weeks, it is term labor. And after 42 weeks, that is 294 days since LMP, it is called post-dated labor or post-term pregnancy. Okay? But delivery means expulsion or extraction of viable fetus. It may be either vaginally or abdominally. If it is done abdominally, it is called cesarean delivery, and if it is done vaginally, it is vaginal, not always normal delivery. Vaginal delivery may be with the help of ventouse or forceps. So, vaginal delivery, if it is delivered vaginally, it is vaginal delivery, and if it is delivered abdominally, it is called cesarean section. So, this is the difference between labor and delivery. Labor is a spontaneous process. So, what are the criteria to be fulfilled to call it a normal labor? Number 1, spontaneous onset of labor. Number 2, presentation must be normal, that is, it must be presented by vertex. The labor should start in term, neither before 37 completed weeks nor after 41 completed weeks. It will be terminated naturally with little or no help. Little help means episiotomy, etc. Not unduly prolonged or complicated, and low risk to both the mother and fetus, that is, both mother and fetus will be in good health after completion of labor. Stages of labor. So, to know active management, you must know the stages, different stages of labor. Labor is divided into 3 stages. First stage is the stage of dilatation, that is, it is defined as from the onset of true labor uterine contraction, through the onset of true labor pain till the full dilatation of the cervix. This is called stage of dilatation and effacement. It is normally 10 to 12 hours in case of primigravida and 6 to 8 hours in multigravida. Second stage which is stage of expulsion, that is from full dilatation of the cervix to the expulsion, complete expulsion of the baby. This is second stage. It is normally 2 hours in primigravida and up to 1 hour in multigravida. Third stage, that is the stage of expulsion of placenta and membranes. It is normally 15 to 30 minutes both in multi and primi. Another stage, the fourth stage, actually everything is delivered, so there is nothing left for fourth stage. So, why there is fourth stage? Because in some books it is written that this is the golden hour after delivery. It is very important because most of the dreaded complications of labor and delivery occur in this stage. So, in fourth stage is the first hour after delivery. The mother and the baby should be kept in the observation room, that is just after delivery. They should not be sent to the ward. They should be kept in observation room for at least 1 hour. It is better if kept for 2 hours. So, because most of the complications do occur in this stage. What are the commonest complications after third stage of labor? Number 1 is PPH, the leading cause of maternal mortality. PPH. Number 2, separation of placenta, that is failure of separation of placenta. Number 3, inversion, acute inversion. Number 4, pulmonary embolism, and number 5, shock. Patient may go in shock. So, To prevent these complications, the patient must be kept under strong vigilance for at least 1 hour after completion of delivery. Okay? Now come to active management of labor. Why it is called active management of labor? Why not only management of labor? Active term is used because of the active involvement of a consultant obstetrician to manage the case. That is why it is called active management of labor. O'Driscoll in 1968 actually pioneered active management of labor. The aim of active management was to reduce the caesarean section rate. Number 2, shorter delivery time, that is delivery is to be completed within 12 hours of onset of true labor pain. Previously when we were students, then 24 hours was the time period for normal delivery, and it was said that sun should not set twice on a laboring woman. So now it is universally accepted that 12 hours should be the limit of normal delivery. It has got two components. One is organizational component and number 2 medical components. Organizational component consists of antenatal education of the mother, her counseling, how to maintain personal hygiene and cleanliness, light exercise, what are the different postures adopted during pregnancy and during labor, and breathing exercises. You all know as the size of the uterus increases, the lung did not get ample space to expand during inspiration. So inspiration rate is increased. So during antenatal period, we teach the patient to practice thoracic respiration, that is abdominal part is restricted. So we ask her to practice expanding the inspiration like this. We teach her that you should inspirate while increasing the rib cage. So these are the breathing exercises. Number 2, routine physical examination like blood pressure, anemia, that should be corrected. Number 3, bedside support and supervision. In all developed countries, husband or relative or patient's mother, etc., they are allowed in the labor room just before delivery. Patient is shifted to labor table. It is seen that allowance of maternal relatives of the mother helps in normal delivery. Number 4, peer review of outcome. We must review every details of a labor, how it affected the course of normal delivery. Now comes medical components. What are the medical components of active management of labor? Number 1, rigid inclusion criteria. That is, we must diagnose that patient is really, she is in labor, and her whether she is actually in labor, whether the cervix is dilated 4 cm or 5 cm at least, then we start active management of labor, not before that. Number 3, strict diagnosis, same thing. You have to diagnose that whether she is having false pain or she is actually having true labor pain. Number 3, early amniotomy. What is amniotomy? That is rupture of membrane. To expedite the process of labor, the amniotic membrane, that is the forewater, is ruptured. Forewater is ruptured. Number 2, frequent assessment of progress of labor. You have to assess the patient frequently, at least hourly vaginal examination to assess the progress of labor. Number 5, use of oxytocin. Use of oxytocin as and when required. That is, if the contraction is not satisfactory, either the amplitude or the frequency of contraction is not satisfactory, we freely use oxytocin to initiate or to augment the uterine contraction. Number 4 is monitoring the fetal heart. Throughout the process of labor, fetal heart should be monitored. And adequate pain relief. Patient, if you don't relieve her pain, she will not cooperate with you. So adequate pain relief, all these points we will discuss in detail. Now, what are the advantages of AML, active management of labor? The main advantage, to shorten the time of delivery, to time of labor, that is shortened labor time. Number 2, early detection of prolonged labor. Number 3, early detection of fetal hypoxia, as we are always every 15 minutes we are checking the fetal heart sound. So, we can assess fetal hypoxia very early. Number 4, less use of analgesics, just remaining by the side of the patient and counseling her and to tell her when she should bear down or not. This will help her a lot, and actually most of the patients complain of pain because of apprehension, out of fear. So, if you support her by her side in one-to-one situation, that is one patient, one attendant, that is not possible in our country. But if you can do that, the patient will require a less amount of analgesic. Number 4, less anxiety, and number 5, it will reduce the cesarean section rate. Now, it is very important both for practical and theoretical examination. What is AMTSL? Active management of third stage of labor. As I told earlier, that as most of the dreaded complications occur after third stage of labor, so this stage should be very carefully, you have to scrutinize this phase very carefully for any sign of PPH or any sign of, if you give episiotomy, whether there is vulval hematoma or excessive bleeding or any tear in the birth canal, etc. So, active management of labor, how will you define it? It is a set of interventions taken to expedite the process of expulsion of the placenta and membranes, that is afterbirths, to expedite the process of expulsion of afterbirths, to particularly to prevent PPH and to cut short the third stage within 5 minutes. Advantages are many. It is seen that, so a set of interventions undertaken after the birth of the baby, because third stage starts after complete birth of the baby, to expedite the process of separation and delivery of the placenta, to prevent PPH, because PPH is the leading cause of maternal death throughout the globe. PPH alone is responsible for more than almost 30% of maternal death throughout the globe. So, I said a set of interventions. So, what are the interventions we do in third stage, in active management of third stage? So, if there is a active management, there must be a standard or classical management used before. So, what are the components of active management? Number 1, use of oxytocin immediately after birth of the baby. We do not wait for the signs of placental, we do not wait for appearance of signs of placental separation. We just after birth of the baby, we give oxytocin within 1 minute of the birth of the baby. Number 2, these are the various oxytocins we can use, we will discuss later. Number 2, delivery of the placenta by controlled contraction as soon as the signs of separation of placenta appear. Actually, we do not wait for all the signs of placental separations to appear. We just give oxytocin before, within 1 minute of delivery. Number 3, delayed cord clamping. Number 4, intermittent assessment of uterine tone. So, these are the 4 components of active management of labor. So, number 1, use of oxytocin immediately after birth of the baby within 1 minute. So, what are the oxytocins we do use in active management of third stage of labor? Number 1, oxytocin 10 units. It is very cheap, available everywhere. It can be given IV 10 units. But the problem is that where in the labor room one sister is delivering and it is to be given IV, so who will give IV? Other group D staff do not give intravenous injection. So, this is the problem with this. But if there is facility and if there is trained people to give IV injection, this is worldwide recommended as the drug of choice in AMTSL. 10 unit oxytocin slowly IV should be given within 1 minute of delivery of the baby. Another problem of oxytocin is it is very heat labile. That is, to maintain its efficacy, it must be refrigerated. If you keep outside fridge, 70% of its potency will be lost within few hours. So this is another problem. To give oxytocin, you must maintain the cold chain. In peripheral areas, in all sub-centers, etc., there may not be any fridge, or there may be fridge, but because of load shedding it is not available. So these two are the drawbacks of oxytocin, that it should be cold chain should be maintained to retain its potency, number one, and number two, it should be given IV. It could be given IM also, but in that case its action will take little longer. Number two, methyl argometrin. This could be given IV or IM. In all cases it could be given, but the only problem is that you cannot give methotrexate to patients with severe hypertension, because it raises the blood pressure. Patient may go into eclamptic fit if you give Methergine to a hypertensive patient. Number three, injection syntrometrin. So to balance this, syntocin on fixed dose, syntocin on 5 unit, and oxytocin 0.5 milligram, argometrin 0.5 milligram, syntrometrin. It was available previously as in the name of syntometril. It could be given IM, where there is no strength stuff for pushing IV injection. It could be given IM. Number four is Carbetocin. Carbetocin is a marvelous drug. It is very potent, at least 4 times stronger than class. It should be given, it could be given IM, IV, etc., and it is heat stable. It does not require any cold chain maintenance. So Carbetocin is a very good drug. The only problem is its price. It is priced around 400 rupees. One ampoule of 100 microgram of Carbetocin amounts to 4 to 450. So it is the only hindrance to use it routinely. Carbetocin. Number five is misoprostol. In countries where all labors are not, all patients are not delivered institutionally, Malaysia, Indonesia, the poorer countries, developing countries, the home delivery to a large extent occur in those countries. There the paramedical staff gives misoprostol 600 microgram. Patient is given just after delivery 600 microgram misoprostol tablet to be taken, but it would be kept under the tongue. Both are equally effective. So these are the various oxytocics we do use in active management of third stage of labor. But prostaglandin, commonly we use carboprost or prostodin, that is prostaglandin F2 alpha, that is given in diagnosed PPH, that is given in to correct, to treat PPH, not to prevent PPH. These are the drugs, these are given to prevent PPH, but prostaglandin F2 alpha is not given to prevent, that is not given routinely. It is given only after diagnosis of PPH. That is, when you treat PPH, you give F2 alpha, prostaglandin F2 alpha. We do not give prostaglandin to prevent PPH. Number two, delivery of the placenta by controlled contraction as soon as the signs of separation of placenta appear. This is what is called Brandt Andrews technique of controlled contraction. Brandt and Andrews, they developed, actually first Brandt developed this method of controlled contraction, that is, when the placenta becomes hard, he used to pull the cord in a controlled manner so that the placenta separates easily. But if you pull the cord before separation of the placenta, there is every chance that the uterus will invert like a inverted umbrella. এই দেখো প্ল্যাসেন্টাটা নরমালি কি হয়, এই ইউট্রাইন ক্যাভিটি
প্ল্যাসেন্টা এরকম লেগে রয়েছে, এই প্ল্যাসেন্টাল কর্ড তুমি যদি এটা টানো, এটা যদি ইফ ইউ পুল ইট বিফোর সেপারেশন, দেন হোয়াট উইল হ্যাপেন? এই প্ল্যাসেন্টা এইভাবে, দিস ইজ কল্ড ইনভার্সন অফ ইউটেরাস। সো ইফ ইউ pull the cord before separation and before the uterus become hard, so uterus will invert. This is a very dreaded complication of third stage of labor. So to prevent inversion, Andrew later introduced abdominal pressure, suprapubic pressure, upward and backward pressure over the uterus. That is, you are pushing the uterus upwards and backwards and pulling the cord downwards. So there is less chance of inversion of placenta. So this is controlled cord traction or Grant Andrews technique. Number 3, delayed cord clamping. Just after delivery, we do not clamp the cord, because in delayed cord clamping, at least after 1 to 3 minutes, it is seen that 80 ml to 100 ml of blood is infused to the baby. Placenta and the cord contains fetal blood, not maternal blood. So if you wait for 1 minute after delivery, the amount of blood in the fetal circulation will regurgitate back to fetus. But if you clamp the cord very early, this blood will be discarded. That baby will be anemic later on. Okay? So delayed cord clamping, now it is a rule. Delayed cord clamping in every labor. There are few exceptions where we put the clamp very early. Number 1, in case of multiple pregnancy, we do not delay. Number 2, Rh negative. Number 3 is when the baby is grossly asphyxiated, that is, she needs immediate resuscitation. We do not wait to clamp the cord. Okay? So this is asked frequently in examination. What are the conditions when we go for early clamping of the cord? So these 3 are the conditions when we clamp the cord earlier. And number 4, intermittent assessment of uterine tone. That is, after delivery, lying by the side of the patient, staying by the side of the patient, you feel the uterine contraction. As soon as the uterus become contracted and hard, then and then only you give controlled cord traction. Don't pull the cord before uterus becomes hard. That is, before the signs of placental separations appear. So another question is, what are the signs of placental separation? How will you know that placenta is separated? There are 4 signs. It should be remembered. How will you know that the placenta is separated? And I will now go for traction of the cord. First sign of placental separation is the uterus becomes hard and globular. After delivery, uterus is not hard. So after some time, when the placenta separates from uterine attachment, uterus become hard and globular, and it is freely mobile from side to side. When placenta was inside the uterus, it is not freely movable. So the first sign is uterus become hard and globular and freely movable from side to side. Number 2, the height of uterus increases. This is very funny, because placenta was there and the height of uterus was below umbilicus. Just after delivery, the height of uterus, suppose this is umbilicus, so uterus was in this level. Placenta was here. So it was below that. What I am saying is, just after separation of the placenta, uterus become more or less round, firm, and its height goes above umbilicus. Why? The volume is reduced, but it goes higher. Can anybody say why? Why should it go upwards? If placenta was here, it was below umbilicus. Placenta is separated, has come down to here. So height should be lower. Why it goes up? Because what happens after delivery, due to extreme stretching of the lower uterine segment, because of weight of the placenta is collapsed. The uterus collapses. lower portion is very much stressed during delivery. So this is the heavier part, it sits in this collapsed lower segment. As soon as placenta is separated, it comes down to this here, and this collapsed area is stressed. That is the reason the uterus goes up. The lower segment, which was collapsed after delivery of the baby, it is stressed by the separated placenta. Placenta comes down and comes here. So this area is stretched. Actually, before separation of placenta, uterus was larger. After separation of placenta, uterus becomes smaller, obviously. But height rises because of stretching of the lower segment. Because placenta occupies lower segment is stretched, so uterus goes above. This is another sign. Number 3 is apparent lengthening of the cord. That is what we do after delivery. Suppose this is a vulval outlet, cord is coming out like this. We clamp the cord flushed with vulva. We pull the cord and clamp the cord flushed with vulva and wait for placental separation. What will happen? When the placenta will separate, placenta will come down, so there will be lengthening. My clamp was here, it will come here. So as if the cord is lengthened. But this is not proper lengthening of cord. Cord does not become longer. Actually, it appears that it has lengthened because the placenta comes down. This is another important side of placental separation. And number 4 is a gas of blood. Passage of gas of blood. একটা সব ঠিক আছে, একটা sudden gas of blood এলো, placenta যে separated হলো, একটা a gas of blood appear in the vulva. তো সেইটাকে আমরা বলি another sign. So these are the 4 signs of placental separation. Number 1, uterus become hard and globular and freely mobile from side to side. Number 2, the height of uterus is increased, it goes above the level of umbilicus. Number 3, apparent lengthening of the umbilical cord. And number 4 is a gas of bleeding. A gas of bleeding, usually you all know placenta separates by 2 methods. One is central method, another is peripheral method. This is called central separation or Schultze method. Central for Schultze and this is for Matthew Duncan or dirty Duncan বলা হয়. Dirty Duncan মানে before placenta blood এসে যাচ্ছে, the field becomes dirty. This is Matthew Duncan. Here what happens? Here placenta separates from the margin. So as soon as placenta separates, there will be gas of blood. But in central separation, in Schultze technique, there is a retroplacental clot, formation of retroplacental clot. The placenta is delivered like an inverted umbrella. That is, in this technique, there will be no prior bleeding. Blood will come after the delivery of the placenta. So these are the 2 different types of separations of placenta: marginal separation and central separation. So in active management of 3rd stage of labor, we do not wait for all these signs to appear. What we previously used to do, that is, after delivery of the baby, we used to wait for half an hour because the 3rd stage limit was up to 30 minutes. So until if the placenta is not delivered within 30 minutes, then we used to call it retained placenta. That is, if the placenta spontaneously does not separate and deliver by 30 minutes, active management should be taken. So retained placenta was defined like that placenta there is no separation or delivery of the placenta after 30 minutes of delivery of the baby. So now we do not wait for 30 minutes. We give oxytocin just after delivery within 1 minute, and as soon as the uterus becomes firm, that is the first sign of placental separation appear, we go for Brandt-Andrews technique of controlled contraction to deliver the placenta to cut short the 3rd stage. And number 2 and most important is to prevent PPH. So this is active management of labor. What are the benefits and drawbacks of active management? Benefits I already told, to reduce the blood loss. It is seen that 80%, what is the amount of blood lost in normal delivery? Do you have any idea? What is the amount of blood lost in a normal delivery? In a normal delivery without episiotomy, the amount of blood lost is almost 500 milliliter. Half liter blood is lost during pregnancy, during delivery, after normal delivery. And if it is done with episiotomy, the amount of loss goes up to 700 to 750 milliliter. And in a normal and in a cesarean section, the amount of blood lost in cesarean section is about 1 liter. So definition of PPH, one definition, that is quantitative definition, was that the PPH, what is PPH? That if the patient loses blood for more than 500 milliliter, it is called PPH. It is one definition. There are 3-4 definitions of PPH. So these are the advantages. It has been seen that blood loss is reduced by 80% by active management of third stage. We can reduce the blood loss to 80%. Number 2, cuts short the second stage, as I already mentioned. It is completed within 5 minutes. Third stage is equal in both primary and multi. First stage 10 to 12 hours in primary gravida, 6 to 8 hours in multi gravida. Second stage 2 hours in primary gravida, half to 1 hour in multi gravida. But third stage is same in both primary and multi gravida. Okay. So what are the complications? If we adopt active management of third stage of labor in each and every case, what could be the complications? Number 1, this is a theoretical risk of retained placenta, because as you know, if you give oxytocin, that is why we previously we did not used to give oxytocin before delivery of the placenta. So because if the uterus contracts, particularly with Methergine, what happens? Methergine, contraction of Methergine, this is another question. The contraction of oxytocin and contraction induced by Methergine are different. Oxytocin induces physiological contraction, normal physiological contraction, that is starts in the fundus and spread downwards. So in oxytocin, retention of placenta is very less, but Methergine, it contracts the uterus as a whole. So this is the difference between the contraction of oxytocin, and that is why we do not induce labor with Methergine. We induce labor with oxytocin, because it mimics the physiological contraction of uterus. That is, the polarity of uterus is maintained. That is not maintained with Methergine. So if the placenta is inside and as a whole uterus contracts, some persons believe that it may result in retention of placenta out because of total contraction of uterus, but this is not true. This is a theoretical risk. If the placenta is separated, it will come out. And the most important one is, if there is undiagnosed multiple pregnancy, twins, you will be astonished to know, nowadays it is not possible because of ultrasound, but it used to happen regularly. We didn't know, but that is, the multiple pregnancy was not diagnosed antenatally. There was no definite means of diagnosing multiple, particularly twin, antenatally. So after the delivery of the baby, if you give oxytocin and then find another baby is left inside the abdomen, so there is certain risk to the baby retained in the cavity. So these two are the complications of active management of third stage of labor. ঠিক আছে? Now active management and classical management, what we used to do before, this is not practiced nowadays, but you have to know how it differs from classical management. In classical management, as I said earlier, that we didn't do anything. We wait for spontaneous separation of the placenta. We waited till the signs of placental separations appear, and after delivery of the placenta, we used to give oxytocin. Oxytocin, here in active management, we give oxytocin just after delivery of the baby.
within 1 minute of the delivery of the baby. But in classical management, classical type of management, we used to give oxytocin after completion of the delivery of the placenta and membranes to prevent the theoretical risk of retention of placenta. Okay? What are the actions to be taken just after in the third stage? Number 1 is active management of the third stage. Number 2, what will you do? We will catheterize the patient. We will repair the episiotomy wound if it is given, and before that we will examine the whole genital tract to diagnose any injury or any bleeding point elsewhere. Okay? So this is what is active management of labor, third stage of labor.